I've talked about this topic so many times, but I think people may benefit. In the first place, let me start formally in the name of God, the most merciful. Actually, the topic I was allocated was assessment of left ventricular dysfunction. And then a few days before when I got the program, they said role of echo in heart failure. Anyway, I thought I would try to do justice to both. And you know why? Because heart failure is a very important topic. And according to WHO, during next decade or two, more than 75% beds of any medical or cardiac units will be occupied by patients with heart failure. So it is very important. And why? The incidence is on rise because of, number one, aging of population, people live longer, and better survival chances after myocardial infarction. Previously, one would die after a massive heart attack. You now have better treatment options, so people live longer. And the longer they live, more likely they are to go into complications, and congestive heart failure or heart failure is one of them. So, in that process, most of these patients are in and out of hospital. What does that mean? That means a tremendous burden on society, both in terms of manpower as well as finances. So, what should we do? The aim should be on preventive aspect. We must try to prevent its occurrence. But before that, another important aim should be to prevent the progression of asymptomatic left ventricular dysfunction from degenerating into heart failure. And for that, echo plays a very important role. And, uh, and when I talk about stages of heart failure or diastolic dysfunction, you would understand that we need to individualize therapy. So, with the help of echo Doppler, we can accurately diagnose or pick up the anatomical defect. We can predict prognosis, we can follow progression, and the most important, that is topic of my discussion, we can plan an appropriate treatment therapy for these patients. And whenever I talk about LV dysfunction or dysfunction, three components are very important. Left atrium, that has already been dealt with by Colonel Azhar. Then we have this thing, mitral inflow, both transthoracic, etc. And third thing is the pulmonary vein. Now, left atrium has been discussed, so I would just like to confine myself to the left ventricular inflow and the briefly pulmonary vein. You must have seen high five presentation. Mine is a poor person because I represent the poor population of Pakistan. But whatever I do, these are handmade slides, but I really put my heart and soul into that. So I think you would appreciate that. Okay. Now, see here, why am I so fond of diastology? Let me tell you that way back in 1996, a new term, diastology, in the field of cardiology was introduced, and that was by two Japanese professors, Nishimura and Akira. And before that, two professors, they are standing here with me, they hosted the first transesophageal echo in Japan. And this is Professor Oki, with whom I worked for 1 year. And this is Professor Matsuzaka here. And then our Pakistani Japanese counterpart, father of cardiology, that is Okamoto. Here, Dr. Tipu is sitting, and his counterpart, Dr. Okamoto. So when I talk, so that is why I like it very much. From Japan, I carried this passion to Mayo Clinic, so I'm really fond of that. So whenever I talk about two peaks, E and A, you must consider they are determined. I'm very fond of pathophysiology. These EA and diastolic events are determined by, number one, rate of myocardial relaxation, left atrial pressure, left ventricular pressure and compliance, and the most important, equally important, loading condition. Please remember that because I will refer to that later. Okay. Now, this I think you will understand. We don't have time to go into pathogenesis, And based on that, we have these 4 stages. Again, I will not, मैं इस पे चली जाऊंगी. Again, people who have worked with Dr. Tajik and his team, there are 5, 6 big chapters. Just to make it a little crisp, I've condensed them into one slide. And on one side, I've written the normal. You can see your E is 1.5 times bigger than A. Obviously, no symptoms. LSI is normal. So is the left ventricular and diastolic pressure. ये अच्छा नहीं है, मैंने पल्मोनरी वेन अपने हाथ से बनाई थी, पीए ने थोड़ी कर दी. मैं अगले में आपको अपना सही वाला पेशेंट के ऊपर बताऊंगी. सो दिस इज नॉर्मल. नाउ दिस क्या पॉइंटर कौन सा था? ये दरमियान वाला. अच्छा. सी नाउ यू कैन सी दिस वन, द मोस्ट कंट्रोवर्शियल. और ये तो भाग दौड़ रहा है भाई, इसको वो कर दें. फखर तुम्हें कहा था ना खड़े रहो इधर ही.
मैं इधर ही खड़ा हूँ.
हाँ.
ये मैम अब आपने इससे इसको ना मैम ये कंप्यूटर पे करेंगी ना.
अच्छा चले, मैं अपनी हाथ ही कर देती हूँ.
ये इससे कर रहे हैं.
कैसे है ये?
ये मैम.
हाँ, ये नहीं भाग रहा. ओके ओके. Yeah, look at this one. This is grade 1 diastolic dysfunction. And mind you, juniors are sitting here. I see in a man who is 75 or 80, you see this kind of EA reversal, it should be called. They write grade 1 diastolic dysfunction. That is not correct. If a person is educated or has some doctor in the family, they really get upset. For labeling a case as that of grade 1, have a look at the deceleration limb. This deceleration time should be prolonged. And then at this stage, there are symptoms on exertion. LSI begins to go up. And then your left ventricular and diastolic pressure is high. And look at the pulmonary vein, S wave is high, D is stunted, and atrial reversal has increased. Then this one, the most treacherous one, the pseudonormal, because to an inexperienced eye, it looks like a normal, but actually it's not. Again, the importance of clinical examination and putting 2 and 2 together comes here. Now here, the patient is severely symptomatic. LSI is very big, and so is the left ventricular and diastolic pressure. But this pattern has a great prognostic value. If you ask these patients to perform Valsalva's maneuver, this pattern goes back to this one. That shows a good prognosis. And also regarding treatment, if you find this kind of pattern in a severely symptomatic patient, you increase the dose of diuretics and 4 pillars that Dr. Shehbaz Qureshi has always been talking about, ARNI, beta blockers, mineralocorticoids, etc. Within 24 hours, the patient shows improvement, and within the next 24 to 48 hours, the pattern goes back here. Now this one, you heard good lectures on restriction. Here again, somewhat like normal, but look at the deceleration limb. It is very crisp, because here the left ventricular and diastolic pressure is so high, the moment your left atrium sends little bit of blood, ekdam se wo niche aa jata hai. And here patient is severely symptomatic, LA is really big, and look at this, यहाँ पे भी A. मैं next please. अच्छा मैं खुद ही करूँगी. फखर तुम नहीं ना कर रहे बहुत. अच्छा चलो ठीक है. ओके. ये मेरा अपना पेपर जो मैंने जापान में ही लिखा और ये हमारा छपा. These are my own echo. ये देखें, this is EA. This is real pulmonary venous flow. You have please PVS1, PV2, PVD and pulmonary vein. देखें ये जो grade 1 था, इसमें आपकी A reversal बढ़ गई और D is stunted. That goes in with this E. Then ये आपका pseudonormal, again big A, और इसकी D बढ़ गई क्योंकि आपका E उधर से आता था, and this is your restriction. Okay. Now for those, some people may work in peripheries or places where you don't have the facility or expertise of Doppler, take the help of your M mode. This is the M mode of your mitral valve. Look at this bump. The Japanese would call it B dash formation, and this is sure 200% sure sign of elevated left ventricular and diastolic pressure. Now again, I was talking about that 4 stages, and I look, do you recognize this lady? मेरे ख्याल आप नहीं मैं पहचानते हूँ, इसको तो पहचानते हैं। अच्छा ये this is Liv Hatley. When I was at Mayo, she's a very humble lady, excellent cardiologist. She's a Danish lady. She was visiting Tajik, and where the young boy of 25 came. Now go back to my point of loading conditions of the heart. He collapsed suddenly. They did his echo and they labeled grade 1 diastolic dysfunction. He was sitting there. Dr. Tajik, have you taken a detailed history? He said, no, he collapsed. You know, these days young people are falling anyway. She said, no, I think he is hypovolemic. They took history and they discovered that a few days earlier, rather maybe 2 days, he had a massive bout of gastroenteritis and decreased preload. They infused glucose or whatever, glucose saline, and the pattern reverted to normal. Similarly, in cases of hyperthermia, hyperthyrotoxicosis, and even in fever, the E wave goes up. And so you have to consider these loading conditions. So this is Dr. Tajik way back in 1992. This was an echo conference in Hawaii where I met again Liv Hatley and Dr. Tajik. इनको तो पहचान सकते हैं ना आप सब? अच्छा, ओके, हाँ, अच्छा, देन ये फिर कुछ हो गया फखर? हाँ, तुम बस करो आगे. Okay. So people were not satisfied. They said something else needs to be done. Loading condition आपका खराब कर देते हैं काम. So then they thought of another modality, which is TDI. They said, let's exclude velocities by flowing blood, myocardium or tissue valve की velocity लेके तो देखे. आगे करो फकर. अच्छा, ये है आपका पल्स TDI. Again, the same thing, systolic, diastolic. Dr. Shahbaz has mentioned it in detail. आगे कर दो. Okay. Then this was fairly good. They excluded the effect of preload. And then what happened? They noticed that TDI was affected by movement of the child. Inspiration, expiration में उसमें गड़बड़ हो जाती है. So then they came up with another modality, strain and strain rate imaging. So it's a dimensionless quantity representing the force producing deformation at a particular point. So, and strain rate represents the local rate of myocardial deformation. Next, karo papa. So, heart failure with preserved ejection fraction, again a big problem. And इसमें आप strain में reduction in longitudinal strain, it shows endocardial ischemia, smaller reduction in radial, and no change in circumferential strain. So it indicates that the problem is in endocardium. So I will not dominate abhi. So you know these are advantages and clinical application of echo. Next, please. Then last but not the least, the role of echo in cardiac resynchronization therapy, because 20-30% do not respond, and echo is an excellent criteria for that. It can localize dysynchrony. Aage kar do. And these are the different modalities by using which you can assess dysynchrony. You must have noticed, thank you, Fakhar, I did not thank the organizers in the beginning because I always remember the great surgeon of armed forces, AMC, who used to say, इश्क मोहताज नहीं लफ्ज़ों का, आशिकी रुख से अया होती है, इश्क का इजहार है खामोशी और हिवस चर्ब जुबान होती है. फखर, इसमें से 70% तेरे लिए थे.